Good morning. Today I'll be discussing our quality improvement project titled Transfusion Goals in ACS. Are we doing it wrong? Our goal with this QI project is to take a deeper look into the transfusions occurring in the setting of acute coronary syndrome or ACS. Over the past 5 years, the OSUMC Transfusion Committee has been assessing, improving, and optimizing the protocol by which we transfuse blood to patients. Monthly, we meet, and at these meetings, we review each transfusion that's flagged for hemoglobin greater than 7. We then perform an individual case review discussing the circumstances surrounding each transfusion and determine the appropriateness level of each transfusion. Over the course of many months of case reviews, we noted a particular pattern among the cases of transfusion deemed unnecessary. Oftentimes, the rationale provided was ACS. However, the patient wasn't actively in acute coronary syndrome. The classic example I can give is a patient with a hemoglobin of 7.1 whose chief complaint on presentation is weakness. When they present, they have a completely normal cardiac workup, normal troponin, no EKG changes. However, because the patient has had a prior stent placement or at some point in time had ACS, they're incorrectly given 1 unit of PRBC and transfused to a hemoglobin goal greater than 8. Now, multiple studies, including both the MINT trial and the TRICS-3 trial, do reflect that an active ACS, a liberal hemoglobin goal of greater than 8, is appropriate, and in fact, non-inferior than a hemoglobin goal of greater than 10. But once again, these are only cases of active ACS. And in many of the reviewed cases, the patient only had a history of ACS. There are no studies currently that show a benefit for a hemoglobin target of greater than 8 with only a history of ACS. So, our plan, in essence, is to take a deeper dive into these unnecessary transfusions. We plan to complete a single institution retrospective analysis to determine if this was a hospital-wide problem and the frequency with which it was occurring. The next step in our plan is then to have a hospital-wide initiative, educational event at Grand Rounds, to discuss the current protocol for transfusions in active ACS versus those in a history of ACS. We'll then, over the next year, reassess and compare the rates of unnecessary transfusions after this educational event. Once again, our goal in all of this is to reduce unnecessary transfusions, decrease hospital wastage of a vital resource, and improve the overall quality of patient care at OSUMC.